Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert. We're second-year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised, Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors. All right, so we're back.
Yep.
Episode 2. After our inaugural episode.
Yep, it wasn't the first and last.
It could have been. It very well could have been.
Well, maybe we
now,
were
question,
kind of close.
did you? We were. Did you listen to the first episode?
I have to be honest, I listened to parts of it, but mostly the parts without me in it, because as I mentioned before too, I think it's still pretty cringy to listen to my own voice.
It is kind of weird to hear your own voice, especially like in a podcast context.
Mm-hmm.
But you know what? So I heard so far we have at least 3 fans of the podcast, which is great.
Oh, really?
Myself, of course. Yeah, myself. You.
Okay, yeah.
And my wife.
Great.
So I would say we're on a good start. And as long as we keep it entertaining and educational, we're on a good roll to fame. And eventually, will not necessary for us to continue working in the medical field. We can retire and just podcast for the rest of our lives.
Oh, that's great.
So anyway, it's been a few weeks since we last talked, or at least long form. How's it been going? How's the program been? How's studying? How are your placements? And how are you enjoying the semester?
Yeah, I mean, we've done a lot this semester. I feel compared to first year, I think not only do we have more lecture material, but also more, I think, these non-academic obligations, things like family medicine, focus family medicine, and also our flex project, right? So personally, I've enjoyed most of what we've studied, even though I don't really go to our lectures. So for instance, pediatrics was kind of interesting, just seeing the range of pathology and how that's different from adults. I think that was pretty interesting. And then now we're doing kidney stuff. And just last week, I think we did ECGs. So I think overall it's been quite interesting, but because we have so many of these different commitments, it has been a bit of a struggle to find time for everything and learn how to balance.
Yeah, it is interesting, hey, like the approach that UBC has to the curriculum. It really seems to me like it's like a medicine crash course, at least in the first 2 years. Because we never linger, we don't linger on any particular subject matter like you did in more traditional medical education, where you might do a few months of the cardiovascular system. You get deep into the physiology, into the anatomy, and so on. And you might not even do any applied clinical cardiovascular or cardiology study. But the way we do it now in UBC, it's like 1 week crash course of material. So I think it really caters to people who are good at the crash course type learning, where they can kind of get the general idea quickly. But for people that really need to go deep into material before they can really grasp it, it'd be very challenging to learn in this style.
Yeah. And I think, there are pros and cons to it, right? So like personally, I also get kind of bored. Like I like getting deep into things, but I also kind of get bored when things drag out for too long. So I like that aspect where, even if you don't like the subject that you're learning right now, like I didn't really like ortho, to be honest. All the different types of fractures and osteoporosis, I felt it was pretty repetitive. But I saw the light at the end of the tunnel because it was only 2 weeks long. So I was like, okay, we're going to get into whatever it was, Parkinson's and psychosis soon. It's not going to last for months, right?
Yeah, you know what? With any type of approach, there's always going to be pros and cons. And I think as a student, you have to just learn to be positive and make the best out of it. Mm-hmm. There's going to be aspects you don't like, but there's going to be aspects that you like. And you can kind of look on the bright side like you've been able to. Okay, you have to learn it fast, but if it's something you don't like, hey, the next week it's going to change and you'll be able to do something else. So I am curious, though, how your family medicine placements have been going. So why don't you quickly, if there are any listeners who kind of don't know what we're talking about, maybe give them a quick summary of what our family med placements are in the first and second year, and then I'd be curious to know how they've been going for you the past few months.
Yeah, sure. So family medicine placements are actually pretty unique to our program. I don't think many schools do it. At least I've not heard of it. So what we do is in first year and through to second year, every semester we have a set amount of hours that we need to do in various settings, but focused in family medicine. So it can be anywhere from a clinic that's found in a supermarket to somebody who rotates in hospital or even in the community, so like home healthcare. So as long as you are working with a family doctor, that is considered a family medicine placement for us. Personally, I've been very lucky. I've been able to stay in the Vancouver region for all my placements so far, and hopefully my next placement next semester. This semester, I think it was a bit of a different experience. It was a different neighborhood in Vancouver that I've not really been exposed to. A bit of an older neighborhood. The patient panel was somewhat older. But like all of my other placements in the past, the patients mainly spoke Cantonese. And so one thing that I've been working on since pretty much day one of med school because of this is learning how to apply and translate literally what we are learning in our lectures and in our clinical skill sessions into a different language and culture. For instance, many names, like colloquial names for diseases or even symptoms, would be considered offensive in English, but they are considered normal to say in Cantonese. So for instance, dementia in Chinese literally translates in English to crazy old person disease, right? So
You're joking.
I'm not. Yeah. And people will say that, like people with dementia or just whatever, they will say that they have this disease using this phrase.
Will they translate it into English and say it to you in English or in Cantonese?
They know, well, either they don't know how to speak English or they will just say the English word, because it's very rare that people have to translate literally. But that's sort of what I'm getting at. Like if you try to translate something literally, or you try to bring in the perspectives that you have in a different culture and try to apply that, it might not always work, and it might sometimes be a bit surprising.
Oh, that's very interesting. I guess I could share. Yeah, I think what comes to mind first when I think about my family med placements in the last few weeks. I guess two things. One is very short, which is that I did two just general family medicine visits so far in the last few months. Mm-hmm. As you know, we have to do one focused family med where we get placed with a family doctor who has some kind of niche. Mm. And in my general placements, I felt my second day was particularly better than my first day, and it was nothing to do with the patients or the clinic. It's just really just a matter of me being in a better mood, me having a better sleep, and me being in a better state of mind. And this is a bit cliche, but it just reminded me of how much like a physician's just general health and state of mind and awakefulness, alertness impacts their ability to care for patients. Because I also, maybe it was just subjective. It wasn't, I didn't objectively get this feedback, but I felt like I was also doing a much better job just as a result of me being in a better mood and kind of being more alert, which makes sense, which is intuitive. Mm-hmm. But more interestingly, I think, my focused family placement was with a younger doctor who did a +1 in geriatrics. Mm-hmm. And she ended up with a group where maybe twice a week she works in kind of long care homes, but most of her days of the week she spends doing house calls. Ah. So she drives around the city and visits families in their homes. And the typical situation, at least what I gathered, because every situation that I saw in the day was as such, and that is an elderly person, usually near the end of life, living at home, mm-hmm. With caregivers. Usually their children or other family, and they're living in the home along with the caregivers. So when you do these house calls, the first maybe half an hour to an hour involves just speaking with the caregivers. Often the elderly person is either bedbound, maybe in some cases they are sitting around, but in the cases at least that I saw, they were sitting around. They had quite severe dementia, so they're not really participating very much in the conversation. And so it was very interesting, just like the first 1 hour is not even seeing the patient or not paying much attention to the patient, at least directly, whereby we're just talking to the caregivers. And it's kind of intuitive, but it was an interesting experience for me because, these caregivers spend so much time with the patients, they have such an intimate understanding of the patient's health, and maybe not be from a medical perspective, but they understand they understand aspects of the patient's health at a much more detailed level than anybody else does. And it almost is akin to, it's not the same as a nursing that you might see in the hospital, because of course the nurses have much more medical knowledge than the average caregiver at home. I don't mean to make that comparison. But what is similar is the fact that the caregivers, like the nurses in the hospital, spend so much more time with the patients than the physicians do. And so they develop these intuitions about the patient's health because they were able to spend so much time just observing the patient, which is similar to nurses and similar to caregivers, means that it's in the physician's best interest to take very seriously what they say, even if it's not at the same kind of medical level that the physician might be thinking in. They have to pay very, very close attention to what the caregivers are saying. Mm-hmm. And it was this process of collaborative and very empathetic, compassionate care, where in this home setting, the physician is playing so many roles, not just, okay, let me observe the patient, let me do some physical exam, come up with a diagnosis, and maybe adjust treatment or initiate new treatment. No. So what is this person's social context? The caregivers are here. How are the caregivers coping? How are their mental health? Are there any obstacles impeding the caregivers from delivering the kind of care that the person needs? Are there home calls? Are there nurses coming in the morning? What kind of government resources are available? What can we get in? So they're really playing like the role of a care coordinator, and even wearing so many hats. There may be a social worker, then doctor, then nurse, then psychiatrist, then et cetera. They're having to play all these roles simultaneously, and that's what was really apparent when I was kind of observing these situations. And I'll finish just by sharing one interesting interaction that really stuck with me. And that was our first home call. It was this lovely, lovely Chinese family who the elderly patient was being cared for by their daughter and their daughter's husband in the home. Okay. And the patient was bedbound, so I didn't see the patient until later. But we started the visit by joining them in their kitchen, where they served us tea. And they're just so hospitable and such warm, lovely people. And it was funny, the daughter first said to me, "Would you like a tea bag or would you like real tea?" And I said, "I guess I'll have to take the real tea. I mean, this tea bag just sounds so inferior now." So they served me some beautiful tea from Hong Kong. And it's lovely packaging, but the tea was delicious. And we just, drank tea and talked for an hour about all the aspects of both the patient and the caregiver's experience in delivering the care. And the one thing that really stuck with me that they said, while they were reviewing the medications, there was one medication, I believe it was to do with stimulating gut motility. I don't remember exactly what kind of medication. It might have been a laxative. It's escaping me now. But the caregiver said, the woman said, "Hey, doctor, isn't this medication I can get over the counter, right? I can just go to Shoppers Drug Mart or London Drugs and buy over the counter, right?" I said, "Yes." "Oh, and it's also covered by a medical services plan, right? I can also get the government to cover it." She said, "Yes." He's like, "Well, you know what? We have the means. I don't want to put an extra burden on the public system if we're able to afford this medication ourselves. So we'll choose to buy this medication privately, as opposed to using public funds and public resources." Mm. And I almost fell off my chair because I've never heard anyone say this. It's quite the opposite, whereby because we pay taxes into a public system, everybody, for the most part, at least my impression is that most people just trying to get everything that they can from the system, that's not an immoral thing to do. That I think that's the reality of a public system where things are freely available. Your tax money goes to it. And if you don't advocate yourself, and if you don't go out and try to get as many resources as possible, there's a risk of you kind of getting left behind, or you don't actually get the resources that you need. So it requires a certain amount of patient advocacy. And so it's not a bad thing that people are trying to get as much from the system as possible. It makes sense. But to hear this woman say, we don't want to use this publicly funded medication because there is a pool of resources that really is meant for everybody. And if we draw from this resource, this means that there is less for somebody else. And we have the means to afford it privately, so we don't need to take away from somebody else. So that was just unbelievable to hear. And these were not, they didn't appear as rich or highly affluent people. They owned a home, but it was a modest home. It wasn't luxurious inside. It was quite apparent that they weren't wealthy in that sense, but still to have this kind of perspective and this moral, this moral perspective and
generosity,
generosity and concern for the welfare of the whole society was really. I'm never going to forget that moment.
Yeah, that's great.
I wanted to share it with you.
No, thanks. Wow. I've not done any home visits, but recently my grandma, who is, I can't remember, she's like 94, 95, something like that. We've recently started home care for her. So every Monday, Wednesday, Friday, a nurse will come in and just make sure that she is eating, showering, bathing, etc., whatnot, because oftentimes I don't get home until later, and my mom also can't look after her as often as well. So that just helps us out like mentally. The only problem is my grandma is hard of hearing, so when the house worker is coming in, she often has to like wait outside for like 10 minutes before my grandma notices. But yeah.
And what's been your general impression so far of the of that kind of service?
I think so. As a client, I think it's very nice. It gives us peace of mind because, for instance, my grandma, she doesn't like to eat alone. Unless someone else is there to eat with her, she might go a whole day without eating, right? But it's just not practical for us to be there at like 3 p.m. or 4 p.m. when she usually eats, or at 5 a.m. when she usually eats breakfast. So having a home worker just come in and make sure that she gets at least one meal a day really helps us out. And then, of course, showering, using a toilet, etc. Because, I think this goes for any culture or any person individually. Like, you don't like to depend on people for your ADLs, your activities of daily living, right? So having somebody who's not a relative help you out with those things is actually a little nicer, I think.
Do you think it in some ways preserves more dignity?
Yeah, absolutely.
Than your family member doing it?
Yep, I think so. Of course, it depends on the relationship and so on. But especially for somebody who was like born in the I think she was born in the 20s or 30s, it really is not normal, or it's hard to accept that your children are taking care of you in that way. Like, yes, providing for you financially and so on, that's expected, but not in terms of like healthcare and so on.
Wow, that's something that I've never considered before, and it makes so much sense. I think there can be sometimes a lack of consideration of this end of life process and what people go through. And it's interesting how we kind of come full circle. Having, when we're born, we need constant care. We're in diapers. Our activities of daily living are being completely cared for, and then we can end up, if for us that are lucky enough to live into our older age, we might kind of end up back where we started in some sense.
And I
But
think
but it is, sorry, to just last point, like we were saying, when you end up back where you started, there's a certain stigma that comes with that because, of course, you're an adult and not a baby.
Yep. No, absolutely. And I think a lot of what we can do as future physicians is try and navigate that for people. So not just simply prescribing a medication or telling them to go to physio, things like that, but thinking, okay, what is going to work for you? So for instance, in my family practice, I mentioned that it's a neighborhood that I haven't really been to before. It's a fairly older neighborhood in Vancouver, not as wealthy. And so most of our patients in that family clinic were, working class people, people who were in their 60s and 70s who weren't able to retire because they were just never making enough money throughout their lives, working, jobs like being a waiter or a waitress or driving a taxi, things like that. And so they're still working, and it's hard for us to just say, oh, you have a fracture of the fifth metatarsal, you need to go to physio. But if you think about it, these people don't have a lot of reserve in terms of like financial capacity. Like they can't just go to their job and ask for a day off. That's not how it works in a lot of these companies. You ask for a day off and you're essentially fired. You can't expect to go back to work the day after and have a job. So it's really hard for us to say, not to even say somebody has a diagnosis can be a little, tough because, if they're sick, then they might like feel stressed and like, okay, and now I can't really go to work. What's going to happen to me? How am I going to provide for myself? And a lot of these people also have children and grandchildren that they still provide for. So we have to think about different ways besides just what is, quote unquote, first line, right? Giving somebody, a painkiller might not necessarily be the first line option in the textbook. But for some of these people who can't go to physio, who can't, whether it's for, because of their job or because of their finances, etc., maybe a painkiller would be a better option.
And this is exacerbated. By the fact that the way that our system in delivering care is set up incentivizes physicians to act quickly, act hastily, and not necessarily have the time to take in someone's life context, which is what you're really saying, at least to me.
Yep.
Is that if we don't consider this person's whole life context, then we're potentially missing out on very impactful aspects of the person's care. And, if you're going to say to a physician, we're going to pay you a lot of money and you're going to sit down for half an hour with this person, I think a lot of physicians would say, great. But it's just not the reality of how the system is set up at the moment. But there are certain disciplines where it is. Like I said, I did the home calls with the doctor. Mm-hmm. That is her job. She spends an hour talking to the caregivers and really considers the whole life context. Physicians like psychiatrists do spend considerable amount of time sitting down and talking to patients and families. But on another note, since we're kind of talking not directly, but about morals and ethics in that world, I did have a question for you. It came up to me recently because, it came up in one of these ethics workshops that we had, because also as a part of our program for the listeners, we do kind of extracurricular workshops and training in ethics and in morals and social topics and interprofessional collaboration and themes like this. So we had maybe about a month ago an ethics workshop where we talked about the pillars of medical ethics, and we framed it within the context of a case. They gave us an ethically challenging case that we had to work in small groups and trying to frame the case using an ethical framework and create recommendations, etc. And what I noticed, one takeaway that I had, other than the practical learning that the session gave me, was that when it comes to the pillars of medical ethics, of which there are 4, being autonomy, beneficence, which is just the doing good unto others, non-maleficence, doing no harm, and justice, which is related to fairness. There's nothing within the ethical framework that says one pillar is more important than the other. However, the pillars are used as a framework within and applied to a given situation. And in the context of that situation, certain pillars might outweigh others, for example. There could be a situation where it is so obvious that the result of the situation will cause one person to exert substantial harm on the other person. And it could be a situation in which justice doesn't really play any role. It's hard to apply justice into the situation. And in that context, that non-maleficence pillar will be the most salient, or will kind of carry the most power in driving that ethical decision. But these are contextual. It's not to say that non-maleficence is the most important pillar of them all. And so what I'm getting to is an observation that I've had, which is that I wanted to ask you to reflect on something that I've noticed, which is that within the younger generation, like our generation, younger, and within the academic context, it almost seems to me that the pillar of autonomy is almost privileged above the other three pillars of ethics as an axiomatic phenomenon, meaning it's privileged over the others before we even know the context of the situation. And I have some ideas about why that might be. Of course, that being a factual statement is still under question. I'm not saying that I objectively know this, but it's an observation that I've made, and I'd love to hear if you have any reflections on that idea.
Sure. I think a lot of people have written about this idea, I guess, that autonomy is prioritized in Western systems of ethics. Maybe it's not like Western, but like really just North American, because in a lot of collectivist societies, autonomy may not be the predominant value, right? So oftentimes it is considered morally favorable to instead prioritize the goals and interests of a group, whether that is your family, whether that's your community, or society in general. And of course, that causes a bit of compromise for individuals, but that's just how things are. It's just how their value system has been established and what's been ingrained into them. So for instance, there are going to be a lot of examples, just like how different people live in different countries and how their economic and health policies have been structured around this. But I agree, yeah. There is a bit of a perhaps overweighting of autonomy in what we've learned, but it makes sense because you have to practice medicine in a way that is appropriate for the culture and society that you're in. If you move to, say, I don't know, Iran or China or Japan, these other countries which have different value systems, then you have to shift your thinking. And I think one of the reasons why we're cautious and have international medical graduates train under the supervision of local doctors before they get licensed here is because there are these subtle cultural differences and nuances in addition to their medical knowledge that we want to place checks and balances on.
That's so interesting. And it makes me think of, because what you're saying to me, it reads like, okay, we have ethical pillars that really should not necessarily be influenced by like social morality and social norms. Like the ethical pillars should be principles, and we should be able to apply them to situations to reduce the amount of sociocultural bias that we have. But I think inevitably what happens is ethical frameworks have to be imposed within a social context, and it makes them not impervious to influences of the society or the cultural norms that are there, which is fascinating.
Yep.
And like you said, we have the same 4 medical ethical principles, but they're going to be applied differently depending on the context and depending on where we are in the world.
Mm-hmm. I think one of the challenges comes when you're in a very multicultural society as we are. You know, Vancouver's a very, very diverse place. And so you have to learn to not only, you have to be familiar with your, what is dogma, I guess, in your area, but also what do your patients think and what are their values. And that's sort of, I think, part of the reason why we want more diverse representation among medical students, and why IMGs are international medical graduates have a bit of a advantage.
So interesting. It's so interesting, and we're no doubt, as we go through our training, and we're going to see these ethical principles in conflict with one another,
Mm-hmm.
and they will change completely depending on the situation and depending on the values of the people involved. I'll share the last thought, and then I want to move on to something else, which was that, even when it comes to autonomy, if you hear the way that medical students, or maybe a typical medical student these days, not them all, where there's a lot of diversity around the students, but a typical medical student might, if there is, I'm going to bring it back to the topic of elderly care, as long as the person is still has the capacity to make their own decisions, almost nothing should infringe on their autonomy to make decisions about what they want to do with their health when they are in their last few years of life. Once again, assuming they have the capacity to do so. But I've directly observed situations, and it's more typically in families that from a foreign culture, or families that have immigrated, where the old person has some degree of autonomy, but really the family is making a collective decision. And it might even be the younger members of the family who are saying, actually, no, you're going to do this, 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 this. And they're almost taking charge of the care of the elderly person, because the health of the individual within the family is much more of a collective, it's much more of a family decision than it would be viewed by maybe a typical medical student who thinks that the person should just make an isolated decision and nothing should impede their ability to make decisions that impact their own body.
And I have like two thoughts about this before we close off. One is, first, just because somebody is from a certain culture or society doesn't mean that they necessarily identify with the norms of that society, right? So, and the corollary to that is, even if you identify with your patient's culture, so like let's say I'm Chinese and my patient is Chinese, it doesn't necessarily mean that they will recognize that connection and that you will be able to leverage that. So a good example that I've heard recently in my portfolio group is a friend who is a white passing indigenous person, and she was interacting with an indigenous patient, but because she's white passing, she really felt like she could connect. Or sorry, because she's indigenous as well, she thought she could connect with the patient. But because she's white passing, the indigenous patient treated her and brushed her off just like any other, physician or medical student, whatever, right? So that's a bit of an interesting thing, but it also applies to anyone who's, it's just the flip side to that, right? So just because you are of sort of the same background, or you look like you are from the same background, doesn't necessarily mean that you can connect or share the same values and norms. And the funny thing is, last week I went to Focus Family Medicine, which was in a urgent care center in Richmond. And one of the patients we saw was a elderly Chinese couple. And we had 3 physicians visit them separately to give their opinions on what was happening to them. And the first physician was a bit older, the second physician was younger, and then the last physician was the youngest. And then when we came in with the last physician, when I say we, me and another medical student, we were talking to them, and they were like, yeah, we don't really trust what what the last two physicians said, because the older physician, he knows the best. He has to be like the most experienced. So, but of course, like age nowadays is not necessarily synonymous with experience, because people start and do different things over the course of their medical training. But I thought it was just kind of curious, or not curious, but like a bit amusing, because it is such a stereotypical thought in Chinese culture that your elders always know the best. So when people want an opinion, they will always go to the person who looks the oldest. It's just something that happens.
It's fascinating and logical.
Yeah,
like it's not.
Yeah, there's a reason for these stereotypes.
Yeah, absolutely.
Anyway,
all right. I say we switch gears. I had two things that I wanted to share with you that are a little bit more academic, and so I want you to choose which one you want to hear first. So I have for you a schema or an algorithm or a thought train on hypoxemia. And I also had some findings of a recent study published that discuss the potential liver protective benefits of GLP-1 agonists. Since in the first episode, we talked about GLP-1 agonists, and we mentioned some of the organ protective effects that are being discovered. And and so there is yet another one. We joked about the drugs being able to reduce your mortgage payments, but there's one other organ that is found to be protective, and that's the liver. So which one of those interests you more to hear about first?
I'm fine just doing it in order. So how about hypoxemia?
Okay, here you go. So here's one thought train for hypoxemia for you, and I'll try not to linger too long, but just give you the general idea, because I thought it was quite good. And it's also hypoxemia at the bedside, so it's relevant to some of the more hospital-based placements that we're going to get soon. And of course, our clinical skills integration sessions, which for people who don't know, we're doing clinical skills training in UBC Medicine year 1 and year 2. We do small group sessions with a tutor, and sometimes with a volunteer patient, and sometimes with a standardized patient, which is just an actor. And of course, this is helping with our clinical skills aptitude. And in second year, we get these integration sessions where we actually go see real patients in the hospital. We have to go see them alone. We get an hour to talk with them, to do a physical exam, and then we have to go present to a attending physician on the ward. So it can be quite nerve-wracking, I think, for students who have never done this before, including myself. Well, I actually wanted to. Did you do yours this week, or no? It's tomorrow.
Yeah, my second one is tomorrow. My first one I did last week.
And the first one will not be in the actual hospital setting yet. It's just a volunteer patient. Okay, so next episode I can ask you about that. But anyways, us second-year medical students who don't really know what we're doing, we have to go see a real inpatient, so hospitalized, just a sick person, and we have to present our findings to an attending. So it can be quite nerve-wracking, but it's a great learning experience. So back to hypoxia at the bedside. You come see a patient. They're, of course, admitted. They're in their bed, and their pulse oximetry, so their oxygen saturation, which, of course, is not the percent saturation of oxygen on hemoglobin, but it is that. I was switching it with arterial blood gases. So if they're wearing a pulse oximeter, like on their finger, it will be estimating the percentage of the hemoglobin that's fully saturated with oxygen. Most of us are up at 99%. Elderly people, they can fall down 97, 95. We're not too concerned, but as it starts getting into the low 90s and especially into the 80s, we're starting to get very, very concerned. Okay, so you go see the patient. First check, is the pulse ox on correctly? So, it might be a seemingly silly point, but if you were to catch this at the beginning and adjust their fingertip pulse oximeter and their sats go up, well then, you have solved it. All right, and then after looking at the pulse ox, first clinical clue, does the oxygen saturation dramatically improve with minimal supplemental oxygen? So their sats are down. We give them some kind of low flow oxygen through usually like nasal cannula. And then so there's an answer, yes, no. did their SATs improve? If their SATs do improve, then we have a normal AA gradient, which of course is the pressure, or it's the gradient between the alveolar air and the arterial blood that is surrounding the alveoli. And this is where, of course, gas exchange is happening. So there's a gradient of pressure there that causes the oxygen to diffuse from the alveolar air across the epithelium and into the blood where it dissolves, binds to hemoglobin, or it just gets left in the blood anyways. So if that gradient is normal, then the SAT should improve with minimal oxygen. And in this case, but they are still hypoxemic. So in this case, we can think of things such as asthma, COPD, opioid overdose, or just increase of the partial pressure of carbon dioxide, which would drive a decrease in the partial pressure of oxygen. So there are some differentials for if your patient has reduced oxygen saturation and it improves with minimal oxygen. If it doesn't, so if you give them some nasal cannula oxygen and there's no improvement in their saturation, then we're thinking of some kind of abnormality in the gradient that we described from the alveoli to the arterial blood. So in this case, the alveoli and the vessels are not communicating, or they're having trouble communicating. You can think about that. So then what? Then you listen. Oh, that's my timer. Don't know what that was for, but sorry about that. So so then we listen. What are the lungs saying? What are the lungs telling us? And then we can have normal breath sounds or abnormal breath sounds with our stethoscopes. So let's say the breath sounds are normal. Auscultation is completely normal. Then we can infer more of a vessel problem. And then in which case we're thinking, is the vessel blocked or bypassed? Blocked, we can think about pulmonary embolism, in which case we would need to get a CTPE or a CT scan, that is with the pulmonary embolism protocol. But let's say the vessel is not blocked, the vessel is bypassed. We can think about pulmonary causes like pulmonary arterial venal malformation or arterial venous malformation. And cardiac causes like a cardiac malformation, a patent foramen ovale, for example, or an atrial or ventricular septal defect, in which case get a transthoracic echocardiogram. Mm-hmm. All right, in our last category, so just to go back to train again, we checked the finger oximeter, it's on correctly. They have not improved with nasal cannula oxygen, and we listened to the lungs, and now we have abnormal breath sounds. Abnormal breath sounds would indicate an alveolar problem, most likely. Let's say we pair this with positive imaging findings on a chest ray or a chest CT. So then we kind of have two categories, which is maybe this is a problem with the pleural space or a problem with the lung parenchyma themselves. So let's consider the lung parenchyma problem. We have abnormal breath sounds, abnormal chest X-ray, and the alveoli are filled with some fluid. That's the most likely scenario. So is it water? Is there pulmonary edema? Is there pus? Is it pneumonia? Is it blood? Is there potential malignancy? And if the alveoli are closed, and this could be a problem now with the pleural space, is it because of air? Is there a pneumothorax that's causing? Is there a pressure cause of collapsed alveoli, or are the alveoli just collapsed? In atelectasis, in collapsed lung. And in the last category, we have fluid in the pleural space causing the hypoxemia, in which case is a pleural effusion, and we can use Light's criteria to categorize the effusion. Was it transudative? Was it exudative? In simple terms, is it mainly water, or is there other cells and protein and debris in the fluid? If it's transudative, we can think of congestive heart failure, liver disease, end-stage renal disease. And if it's exudative, we're thinking more infection, cancer, autoimmune. And so there you have it. That's hypoxemia at the bedside. By no means completely inclusive of all the things that could be going on, but kind of a practical guide to thinking through it. What do you think about that?
I think it's good. It's very comprehensive, and it reminded me of certain things like Light's criteria. I believe we learned it last year. We've not touched it since. A lot of rest we've not touched. We did a bit of it in our pediatrics block, but as I mentioned earlier in the podcast, the pathology in kids is quite different from the pathology in adults. You mentioned patent foramen ovale as well as ASD. I was wondering, do you know if a left to right shunt, as in patent foramen ovale or ASD, would cause a significant hypoxemia?
Whether or not a left to right shunt would or could cause hypoxemia?
Yep.
I mean, without thinking, my reflexive answer would be, do I have a reflexive answer? Because of course this is, let's just let's just simplify, take a step back. Of course, when we have a right to left shunt, now the answer is a clear yes, because we're getting deoxygenated blood shunted over to the left side of the heart and then being pumped into systemic circulation. It's effectively now reduced the oxygen saturation because of the mixing of oxygenated and deoxygenated blood. But to your point, what if oxygenated blood is being shunted into the right side of the heart and pumped through the pulmonary circulation? You know what? I'm going to defer to you because if you were to listen to me think through this systematically, it might take 20 minutes. So please enlighten me. This is very interesting.
Well, my short answer is generally no. And in fact, that's why a lot of these left to right shunts, according to what I've read, are generally asymptomatic. So you can have a PFO that goes undetected, or a small ASD that goes undetected for years and years, maybe even never, until like adulthood or something. And generally the only symptoms apparently are things like reduced exercise tolerance, not exercise intolerance. So, they might not be able to... Sorry, go ahead.
It must affect, I was just saying, does it affect your cardiac output because you're shunting blood away from each ejection?
Yes, but I don't think it's to the extent of causing a dilated cardiomyopathy or volume overload, because their heart is still normal. It's just, they lose a bit of stroke volume every beat. And so, yeah, you have a bit of reduced exercise tolerance. They're not going to be, running like crazy marathons, but they might get a little tired earlier than other people. They might have a little bit of cold intolerance, but generally asymptomatic.
Fascinating. And what if, over time, could a left to right shunt cause congestive heart failure, for example? Because then we might be able to we could say over time they get congestive heart failure, which causes a transidative pleural effusion, and now they have hypoxemia.
Mm-hmm. Yeah, so I think it has to be either like super chronic or a large defect. And if it's a large defect, you usually expect to pick it up a little earlier. And the second thing that you just reminded me of is, maybe I've mentioned this to you before, but apparently you cannot have a pericardial effusion from left heart failure alone. You have to have right heart failure to have a pericardial effusion, which I thought was quite interesting.
And is the mechanism clear for that?
I think it has to do with the fact that the right heart is directly connected to the venous system, and then when right heart failure occurs, there's going to be more fluid seeping out into the pericardial space. I don't think left heart failure generally evolves that way. Usually, if there's a backflow, it just goes into the lungs, and so you get a pulmonary effusion or edema rather than pericardial. So left heart alone should not cause a pericardial effusion. So if you see a pericardial effusion and they have left heart failure, that means that they probably also have a failing right heart as well, or right ventricle.
Fascinating.
Apparently.
Well, we can elaborate on that in a future episode, because I still find, right and left heart pressures, congestive heart failure, right atrial pressure versus systemic volume status. All of these concepts to me I'm starting to grasp them, but really a lot of them are still remain elusive in the fact that there seems to be so many factors to consider, and the more I learn about it, I feel like the less confident I am at making any kind of judgment on volume status or right atrial pressure, etc.
Same. And I think that is sort of why it is quite complicated to learn how to detect it. So, of course, there are physical exams, physical exam techniques that we can do, like looking for the JVP, looking for peripheral edema, doing ultrasound for volume status, and then, of course, ECG. But none of these techniques alone tell us what's going on. You have to integrate all of them. And that's why we have to understand all those different patterns.
All right, why don't we come to the end here by discussing this emerging research on the hepatoprotective features of some of these metabolic drugs that are so common these days, or so popular. What do you think about that?
Sure.
Okay, so I haven't thoroughly looked into this study, so I'll just be able to give the general idea, but I thought it was very interesting. So this was a article, and if people want to look it up, the article title is Metabolic Dysfunction Associated Steatotic Liver Disease. And this was published very recently. It's published, or at least recently, compared to when we're recording this episode. So it was published September 25th to 2025 in New England Journal of Medicine. So do you consider it to be the most prestigious journal?
In medicine, probably.
Yes.
Yeah.
Yeah. So no big deal, publication in what Delbert Yip, co-founder of Two Guys in Scrubs, considers the the most prestigious medical journal. Anyways, I do love their format and how they chosen to. I love their template for their articles. It's very visually appealing. Anyway, okay, so metabolic dysfunction associated steatotic liver disease. It is a review article, so it's not original research. And the article discusses many different topics, but we'll try and keep it more narrow as it pertains to the hepatoprotective effects of GLP-1 agonists and similar metabolic medications. So it talks about a few different kind of metabolic related liver diseases, but I think a lot of the results are to do with a condition called metabolic dysfunction associated steatohepatitis. So this is essentially fatty liver disease because of metabolic drivers.
Right. So it's not alcohol related. I think that's the other main category.
Yeah. So importantly, exactly like you said, this was not alcohol. It's not alcohol related. We can think about metabolic factors. It's funny when we say metabolic sometimes because it's such a big word. It's like metabolism is everything. But when we say metabolic, we tend to think about things such as insulin sensitivity or diabetes, hypertension, obesity, exercise capacity, fitness, these kind of ideas, dyslipidemia, etc. So let's say you have this constellation of metabolic drivers. This can cause metabolic dysfunction associated steatohepatitis, and we're going to call it MASH from now on because it's easier for me to remember. And like Delbert said, this is non-alcoholic. So what are some of the outcomes we can look at when it comes to MASH? Are things like, let me see here. So some of the primary endpoints were resolution of MAS without worsening of the liver fibrosis. And we have reduction in fibrosis of the liver in MASH. And let's just, for simplicity's sake, let's just consider those the two most important primary endpoints. So when you have fatty liver, you have fibrosis, scarring, sclerosis, and as we know, cirrhosis is the final common pathway of all liver disease. In any state, and I think this is a general principle, I'm veering a little bit away from the article now, but just in a general principle within medicine and pathophysiology, is whenever we have a disease process that's creating like repeated scarring or fibrosis type changes to the tissue, this is almost always associated with poor outcomes in some way. So we can think of any relapsing, remitting, inflammatory process, traumatic process, a process in which there are like immune cells being deposited in tissues. It's not so simple, but a common factor across all these different mechanisms of tissue injury and tissue changes that will result in adverse health outcomes is kind of fibrosis, sclerosis, scarring of tissues, which reduce its ability to function properly. As you can imagine, we were just doing Kidney Week, where we're talking, about nephritic syndromes, damage to the glomerular basement membrane, the glomerulus itself. Essentially, it's getting damaged, scarred, fibrosed. We're having thick scar-like tissue replacing functional tissue. This decreases function, and of course, if we have reduced organ functioning, this is associated with bad outcomes. Anyways, let's get back to the study. So we have MASH, and we have endpoints such as the resolution of MASH without the worsening of liver fibrosis, and we also have the degree of the liver fibrosis. So we have these kind of incretin-based therapies, and particularly the GLP-1 agonists, which I'll just focus on here. So what were the results? There was a phase 3 ESSENCE trial that was looking at the effects of semaglutide, which is a GLP-1 agonist. Is semaglutide is that Ozempic by brand name? I always forget.
Semaglutide?
Yeah.
Yeah, I think so.
So funny where we choose to stress the syllables. I always, people use around semaglutide, semaglutide. Anyway.
Apparently, so we according to the pharmacist, if you say it wrong, the pharmacist will laugh at you behind your back.
I'm sure, especially the hospital pharmacists are just laughing at all the trainees or the docs. Anyway, okay, so let's phase 3 ESSENCE trial, semaglutide, 2.4 milligrams weekly for 72 weeks. So what about the resolution of MASH? There was 62.9% resolution versus 34% in placebo, with a p-value of less than 0.001. Likewise, in terms of the fibrosis reduction, 37% versus 22% in placebo, with the same p-value. So we see with the 72-week treatment of semaglutide in MASH patients, we saw significant reduction in MASH resolution and significant reduction in hepatic fibrosis in the treatment group. Fascinating. And we found similar results across different medications, such as tirzepatide, which is both a GLP-1 agonist and a GIP agonist, and as well as survodutide, which is also a dual GLP-1 agonist and glucagon agonist. So, fascinating. Once again, we're continuing to find the seemingly magical effects of some of these peptide hormone-based, incretin-based treatments. And just fascinating. Absolutely fascinating.
Yep. And I think it's showing a lot of my friends who know nothing, who probably never took biology even, are aware of Ozempic and so on and so forth. It's really quite impressive how much of a social movement it has become. Maybe not social movement, but like how much people are aware of it, even if they don't really care normally about medicine or that sort of thing.
Absolutely. And I really hope that this stigma around using these drugs for weight loss is combated and dealt with. I hope the stigma disappears as well, or is just minimized, because the amount of times I hear people just shaming people for wanting to use these drugs for weight loss, it's I don't know exactly where that's coming from, because first of all, we know scientifically that people who are obese and struggle to lose weight, it is not so simple as it's not a character flaw. It's not lack of motivation, they're lazy, et cetera, et cetera, et cetera. We know now that there's a very strong biological, genetic component to their difficulties in going from obese phenotype to, let's say, an athletic one.
Mm.
Maybe it's not 100%, it's not 100% biologic genetic. There are personal factors, but they're not significant, or at least we don't think that they are more significant than the biologic genetic factors. So, and we know the health consequences of having an obese phenotype over time are so drastic. So why people shouldn't be able to use a medication for that has a myriad of health benefits, why people would take some kind of issue with that is it's fascinating. It's interesting, but I also wish that it was less.
That is a whole can of worms and rabbit hole that would probably take a long time to flesh out, I think. Why people have certain views towards using medication, not using medication, vaccines,
Totally.
psychiatric conditions that are in and those that are out, depending on, the time of year or something like that, things like that. Yeah.
Whether someone's a crazy old person or not.
Yes.
All right, so that's been about an hour. I'd say we sign ourselves off, and just with telling the listeners, we plan in future episodes, we plan to have guests. We have a whole bunch of very interesting guests that are on our mind that would love to come talk to us. And I think it would add a really interesting dimension to our discussions, and we can probe and ask provoking questions to, let's say, experts from a number of fields. We hope to have some PhD academics, physicians, could be even people who are more in social work, recreation, politics, government, etc. And we'll get them on Two Guys in Scrubs, and we'll pick their brains a little bit. What do you think about that?
Yeah. Maybe they don't have to wear scrubs though.
Well, we should actually have everyone who comes on the podcast should get an honorarium, which is just a pair of scrubs. But they have to be like used and ratty with a few holes in them, because the new ones are a little bit expensive.
True.
Until we become famous, and then the podcast can fund all kinds of things.
All right.
All right, you want to sign us off? Let's hear the jingle.
All right. Okay. Jingle. That was Two Guys in Scrubs. If you want to support the podcast, leave us a like or review wherever you listen to your podcasts. Thanks for listening, and we'll see you next time.
Jingle, jingle. Jingle, jingle. Beep.